there's really not one way to do a max implant. And that's a very important point to take on board right up front. And the reason for saying that is because the molar sites that we're dealing with are highly, highly variable. There's not two the same. And it makes it difficult to therefore document a step-by-step technique and to teach a very specific technique. This is not an easy implant to place. It's not an implant that should be used by someone doing their first implants. It really requires an experienced operator to maximize the benefit of the implant. There are also significant differences in treating maxillary molar sites and mandibular sites, so I'll come to that later. One of the key factors, and this is an arbitrary classification which makes it easier to communicate surgical technique. So it has its limitations, but the key factors to consider is how much bone is in the socket of the molar site. So if that's your starting point, then we have a basis for communicating and discussing and rationalizing these techniques. So we can identify three cases, and I'm going to call these case 1, case 2, and case 3. Case 1 would be where there's a lot of bone within the socket. So if you take the tooth out and you look at it, there's 3 root compartments possibly. Not all of them have 3 root compartments to begin with. But the amount of bone between those compartments would be considered enough bone to call a lot of bone, which would allow for a drilling technique. That would seem to be very simple and easy to do. It would be obvious. The unfortunate thing is that very few molars fall into that category at all. So it's there to create a hierarchy, but really it's insignificant in terms of our clinical lives because not many of them look like that. The second, with little bone, is much more frequent. That's probably the greater majority of our cases have little bone in the socket. And this happens to be extremely difficult to deal with. So I'm going to spend quite a bit of time describing how we deal with that. And then the third case, case 3, is where there's no bone in the socket. In other words, you've got a tapered fused root, and we see a good number of those, and it's also a difficult area to deal with. In discussing the surgical technique, we need to look at the specific devices that are provided by the manufacturer for preparing the implant sites. So the first is a dedicated drill, and for each implant diameter and length there is a specific drill. And obviously that's configured to the taper, etc. of that implant, and that's pretty much a norm in the industry. The second device, however, is a unique device. It's unique to this implant in that it's a tap with a very specific configuration, i.e. a steep taper, which is unusual for a tap. Normally taps are fairly parallel-sided, and apically they have a small taper to allow them to cut into a pre-prepared pilot hole. So this breaks away from that norm of a tap. In the second instance, also, it's unique in that it has a spiral flute, a very strongly spiraled flute, which a standard tap doesn't have. Standard taps, garage taps, have got a vertical flute. And the flutes are provided on a tap in either case for providing a cutting edge. But with a spiral flute like this, we're able to achieve a very sharp cutting edge. The angles become more acute and provide a sharper cutting efficiency. But the reason that spiral flute exists in the first place is that a vertical flute would engage struts of bone within the socket and break them off. And we did that. Our first increments, our first evolutions of these were tapered in the silhouette of the implant, but they had vertical flutes. And the minute we used them, we understood that they were not practical. And we went immediately and changed them and made spiral flutes. And the spiral flutes have served the purpose of not engaging struts of bone and not breaking them off at all. Instead, they provide very efficient cutting. So a great deal of the focus that I put on surgical technique is around the tap. The other feature of the tap is that it carries a hexagon on the shaft. And the importance of that is that this tap requires a great deal of torque to introduce it into a site, and we need a feature on which to get hold of it and rotate it with high force, and that happens to be this large size hexagon. It carries a latch grip so that we can pick it up in a handpiece and introduce it into the site. But obviously this latch type can't deal with much force. So we have to have a secondary feature in the form of the hex. Right, so we'll speak more about the tap, how we use it, etc. The third item you see here was originally developed as an osteotome to form the sockets. But that use has fallen away, and today this osteotome is included in the sets for the simple purpose of a try-in part. And it's operator dependent as to whether you use that. I'm going to show you a technique where that role falls away because of the way we use the tap. So we'll get to that. If we look at our case classifications, case 1, lots of bone. Case 2, typical molar extraction site with 1, 2, or 3 compartments, but usually little bone between them. And then case 3, no bone. So let's see how we deal with these. In case 1, the obvious technique here is you've extracted the tooth, you're confronted with significant bone volume, and you'll set about a drilling protocol. You'll go through a pilot hole and a sequence of drills, tapered drills leading up to the size of implant body that you envisage. In this case, being a max implant, I would add to that beside it being a drilling protocol, it has to be a drill and tap protocol. We're going to use the tap in every instance. Incidentally, the max drills have also gone through a cycle of evolution where we've now got a drill pattern, a design, which is less aggressive than the older type. And the reason for changing the depth of these flutes to make it less aggressive is, again, to not break off small struts of bone inside the socket, so that we can preserve as much of the structure within those molar sockets as possible while developing the shape for the implant. And you'll see that it also has a feature here of significant guiding planes that are non-cutting, so that it can stabilize the drill in a socket. One of the problems in drilling with a drill like this is to get it to work in a stable fashion within the socket. So we've tried to improve that. The tap provides for efficient cutting, but it has to have a pilot hole. The very nature of a tap is that it cannot be the primary instrument in a site. It follows on from pilot hole preparation. And that's critical in your technique, is that you have to have an adequate pilot hole to accommodate the tap. The tap is designed to be used in a handpiece in the first instance because it has a latch at the top. It's taken to the site at low speed and high torque as per your implant insertion speed and torque. The convenience of this is that you can carry it to the site on a handpiece. It's easy to get there because of the contra-angle handpiece and the extent of it. But obviously it will torque out very quickly because of the great taper. And then we disconnect the handpiece and use the hex on the shaft to hand wrench it to full depth. And the hand wrenching is necessary because we develop higher forces with the tap. In this example, you see a tooth that's being sectioned into 3 roots. The tooth is removed, there's plenty of bone, and we set about a pilot preparation. So in our case 1, one of the important things to know is that the pilot hole should be positioned mesial to the midpoint of the socket and slightly palatal. So that's something that we've learned over time. The immediate instinct one may have here is to start in the middle, have the implant in the middle, so start the pilot hole in the middle. And what that leads to is a distal shift of the implant and very often a buccal shift of the implant. And that happens most of the time because of the natural anatomy of the sockets being swept to the distal. If you look at this image here, typically the mesiobuccal root curves to the distal buccal root is angulated to the distal, and the palatal root, besides being palatally divergent, also usually migrates to the distal. So what happens to you here is that as you place your burrs through the center of the socket, all of them get displaced by the anatomy more and more distally with each successive instrument. So we learned that by hard experience. So the point to take home from this is to always position mesially and palatally if you're doing a drilling technique. The other thing that we want to guard against is that the interproximal dimension of bone between the distal of the first molar and the mesial of the second molar is often very, very thin or infinitely thin or even absent. So even just taking this tooth out, we see dentine exposed below the level of what would have been the soft tissue attachment. There isn't a bony septum there in this coal area. So the last thing we want to do is to have a distal migrating implant that ends up biting into the dentine of the second molar. And there are many cases like that that I've seen. And so I ask you not to do that, to be very aware of positioning mesially. The other thing that drives you distally is that between the distal of the premolar and the mesial of the molar, there's a very substantial shelf of bone here. That will also butt the instruments further distally. So do be careful of that. This is a danger zone that you should visualize and try and stay away from. So there's our preparation. The protocol that I recommend in the case of a drill site like this, which I say is an absolute minority of our cases, is to drill to a 6 millimeter taper drill and then to use a tap. That's our protocol here. 6 millimeter taper drill and then to use a tap. And the tap that you would use then in the 6 millimeter hole that you've cut with a burr is a 7 millimeter diameter tap. So the pertinent points here with a pilot hole, go mesial, go palatal, use a taper drill sequence to a 6 and then use a tap. The protocol that we prefer is to use a tap in every single drill site. In other words, your finishing instrument should always be the tap. You see an example here of a tap in sight. The other advantage we take of having wrenched the tap into sight is obviously you can feel the insertion torque that's required. You know that you can seat it to full depth, therefore your implant will go to full depth. The risk one runs with a max implant that's highly tapered is that you get it stuck. That's a real risk. By virtue of the fact that it generates a lot of primary stability, equally, the risk of that is that you get an implant stuck before it's fully seated. The only way to know for sure, 100% sure, that you won't get your implant stuck and ruin your day is that you use a max tap to full depth, therefore verifying that your preparation is adequate for the implant that you will now select and open. So many operators that we've seen over the years have ignored the existence of the tap, ignored the benefits and the use of the tap. But I would implore you to make it an absolute rule for yourself to always use a tap. If you don't do that, the possibility of you getting an implant stuck that's not at full depth, and the frustration of having to remove that implant and probably destroy it in the process and then open another implant which may be shorter or smaller to get it to site, all of those frustrations can be avoided simply by using the tap. So one of the very important steps in the protocol that I'm recommending to you is that you insert the tap to the point that you're satisfied with it. You leave it in sight and take a radiograph and verify. Check your distance to adjacent structures. Check your depth of placement relative to the buccal crest of bone. And check the position relative to the sinus. If this was intruding into the sinus, you may make a decision that if this is an 11 millimeter tap, you're going to use a 9 millimeter implant. You've got an option here to adjust something. If the tap's in sight and there's something that you don't like, either it's too long or it's not deep enough, you've got ample opportunity to adjust it. And the way in which you can adjust it is twofold. One is you could change the diameter of the tap and translate that to the implant, or two, you can adjust the length of the tap and translate that to the implant that you're going to succeed it with. Right, so it's absolutely a golden thread through making this protocol predictable is that a tap be used as a precursor to your implant. So there you see the tap and the equivalent implant in sight. Notice again the depth of placement relative to the interproximal height of bone. The datum that we use for depth of placement is to measure from the buccal crest or the palatal crest, whichever is the most apical, and place the head of the implant preferably 2 millimeters below crest of bone. Remembering that we're taking account of the inevitable bone remodeling that will take place as a result of having extracted this tooth. You'll see in this example and most cases that we do is that not all of the socket spaces will be involved in the site preparation, and that's good. We're not aiming to fill the entire socket and all the voids with the implant. Far from it. We don't need to do that. All we're trying to achieve is primary stability of the device at adequate depth and torque, and the spaces around the implant will fill in by healing. So definitely don't aim to fill the socket. That would be completely erroneous protocol. This is the case fitted with a temporary healing abutment. I'll talk a little bit about a choice of temporary healing abutment. We like to use 2-part temporary abutments. They've got definitive restorative advantage over 1-part temporary healing abutments, and also allow us to customize the abutment to fill voids. One of the criteria of choosing a temporary abutment is that we choose an abutment of sufficient dimension to gently and fairly passively approximate the soft tissue to the abutment as far as possible to support the soft tissue. What we've learned to do, and also through the work of Tar now, is not to pull the soft tissue aggressively inwards to try and close the soft tissue apertures. The documentation on this seems to suggest that if we strain the tissue to close it across the apertures, that we compromise the crest of bone and induce more resorption than necessary. So the protocol has become to choose a component of sufficient dimension to allow passive adaptation and approximation of tissues, and then we use artificial or biomaterial substitutes. This is an example we can see of an implant drifting to distal. That site looked pretty center in the socket, but as we expand it and we place the implant, you can see there's some degree of migration to the distal. And we want to be very careful to avoid contact between the implant and the next tooth. So you can see that by placing this implant, we've still got significant voids around the implant where threads are entirely visible. And by obturating the soft tissue aperture and allowing those voids to fill simply with blood clot, they heal completely with bone. This is a week later at suture removal. You can see the beautiful healing that's taken place here. In this case, because of the dimension of the temporary abutment, only a simple suture in the mesial and a simple suture on the distal was adequate to approximate the tissue. No grafting was required, no other materials were required. Simply protecting the space of the sockets so that blood clot can form and maintain stability there to allow natural healing to take place. This human skull example illustrates the danger zone between the distal of the first molar socket, which is this one, and the mesial of the second molar socket, which is back here. The bony separation in this interproximal region between two molars can be extremely small in dimension. If we fall into the trap of starting a pilot hole in the middle of the socket, we'll definitely end up here. The problem with folk doing this max implant without looking at this training material is that they may be tempted to take the tooth out and look at the intersection of bone, the septa of bone, and use that position as a logical place to place a pilot hole. Because where else do you place a pilot hole other than that intersection of bone? And that's a trap. If you do that and you start in that intersection of bone, you'll inevitably end up in the wrong place. That should not be your criteria. So you see, as we expand this osteotomy, that exact problem is occurring. We've got plenty of dimension to the mesial, but very little to the distal. So the message is, don't do this. Don't take the tooth out and start the pilot hole in the intersection of bone. That's not the right place. I'm asking that you consider using the max tap in every single drill site, even if you're confident with the drill site that you prepared. The problem is it's not a threaded device yet until you've carried the tap to site. So what it does for us, the use of the tap adds predictability. The predictable word ends up on each of these points. Predictable site preparation. It is the last preparation instrument. It's an instrument with cutting capacity. It gives us predictability of primary stability. In other words, if you go down with a tap and you torque out with a tap to the point you're not comfortable and you haven't got enough depth, you know that the implant can't possibly reach depth. That's very valuable to know that up front. You know the insertion torque required, and you know how much depth of placement you can achieve. If you find that you can't achieve adequate depth of placement with a tap, you've got options. You can sort it out before you open the implant. And in that way, you won't get the implant stuck. In this radiograph, you see the tap with the adapter in place, which engages the hex feature on the shaft, which is connected to a hand wrench, which allows us to hand drive the tap into the site. So here you just see a clinical example, a very typical example. This is an everyday type of situation. You remove a molar, it's sinus approximating, you've got very limited height of bone. There's a pathology on the mesiobuccal root, which is very typical, but we're able to place a device immediately into that extraction socket with excellent primary stability. We've nudged it just into the floor of the sinus without extending unnecessarily into the sinus, but just to use the corticated floor of the sinus for stability. And you see at 3 months a restoration placed. It was allowed to heal without loading, and a restoration placed at 3 months. And you see it at 2 years. Notice the bone remodeling, the bone fill into the mesiobuccal socket that was here without any grafting material. And at 2 years, you see the stability of the interproximal crests of bone despite the deep prosthetic connection. The same case at 5.5 years, entirely stable. Look at the maintenance of that bone height and the approximation of bone to the device and the prosthetic crown, in fact, despite the depth of placement. So we're confident in saying that if you use pre-machine fit in the form of a passive abutment and you maintain good screw force in the form of a gold screw with good preload, you can have a junction below soft tissue, even with an external hex that is completely compatible with health over time. And obviously there are people who would detract from that argument by saying that an external hex is not a stable connection and won't allow for bone height maintenance. Well, in the presence of an adequate platform and good fit, you definitely can, and this is the proof of it. The same case we see on bite wing radiographs and periapical radiograph at 5.5 years. The pattern on the two radiographs looks slightly different. The bite wing is probably closest to the anatomically correct situation. What we see often on these cases is that in the mesiobuccal area, there's a very slight deficiency that develops over time. And this is probably related to the anatomy of the mesiobuccal root and the buccal plate over it. We know from anatomical studies of even healthy first molars that those buccal plates often bear fenestrations and dehiscences with exposure of the roots. And therefore, when we extract these teeth, even using atraumatic techniques, we probably have deficiencies of the buccal plate which may be unseen, and that may account for resorption and losses in these areas. One of the benefits of a max implant with its wider prosthetic table is that we get an emergence profile of these implants that looks very much like a real molar tooth, and therefore the embrasure spaces are not excessive, and therefore the papillae have a semblance of fill in these spaces. And what we find as a result of that is patients don't complain of food impaction in these areas, and that's a really nice benefit of cases where we can use a broader platform, is we make the tooth anatomically and physiologically more correct to what a tooth should look like. And that's another satisfying aspect of the max implant. This particular restoration was made with zirconia. It can either be copy milled, which probably nobody does anymore. They all CAD-CAM generated zirconia. And in this case, full veneering was done, which we don't do today. We do monolithics, probably with buccal veneering where aesthetics demands it. In this case, it's a large platform implant. It's a 7 millimeter diameter restoration or restorative interface on passive abutment. This is the concept of the passive abutment, which I'll show to you just briefly. It's a titanium pre-machined interface. In this case, an engaging type, meaning that it has a hexagon that fits the hex of the implant, but also a larger hexagon that indexes the crown onto the passive abutment from coronally. The concept is that cementation is done outside of the mouth on the master model. The passive abutment titanium part is held down onto the analog with this peak screw, a tiny screw with a hex in the top of it. It allows us to place the luting medium onto the part and insert the crown overhead, and seating it and setting the cement, and then burring out this little screw to allow the construction, the assembly of crown and passive abutment to be withdrawn from the model. We then have polishing protectors which are placed on this face to protect it entirely from any mishap with the polishing procedure. The cement line and the junction to the crown is polished to very fine extent under magnification with the polishing protector in place, and we can then carry it to the mouth in one piece. This is a schematic of the passive. The green would be the laboratory analog, and the grey here would be the passive abutment titanium ring, and the pink would be the peak luting screw. The luting screw clamps the titanium ring tightly down onto the analog so that that interface is assured. We don't want that to move about in the luting process for accuracy. The restoration is made from a plastic cylinder, which you see depicted in white here, which can either be a cast manufacturing process, or it can be copied and milled if you're doing a zirconia structure, for example. The essence of the concept is that the inaccuracies of the manufacturing process, whether casting or milling, will be built into this part. And the interface in titanium will be applied to it retrospectively by means of the luting line. And in that way, we achieve machined fit to machined fit in every single restoration. In the final assembly, once the luting is done, you'll see that the prosthetic screw seats on a screw seat overhead the assembly, and in that way it clamps the restoration to the titanium part through the medium of the cement line and retains the entire assembly in compression. So the big difference between this passive abutment and a tie base, for example, is that the retention of this prosthesis is not derived from the cement line at all. The retention is a purely screw retained compression, and the cement line is merely a space filler. All right, having established the drill and tap philosophy, let's look at case 2. Case 2 is very important to understand because it's the majority of our max cases. And it just happens to be an extremely difficult scenario to deal with. If you're faced with this, you've extracted the tooth and you look at these bony septum, and you attempt to drill into this area, the immediate thing you'll do is you'll prepare where the best intersection of bone is, where you can find a platform for your pilot drill. And the minute you do that, you're already in the wrong place, because you'll see that that intersection of bone is typically too distal in the socket. But secondly, what happens is that the minute you start to expand your pilot osteotomy with the bigger and bigger drills, you'll fall out of the bone entirely, and the drill will start jumping around in the socket and knocking off the remainder of these bony septa. And that's an immediate frustration which has arisen with people starting to do the max. So you have difficulty placing the pilot hole, and then when you've done that, if you can get it done, the drill falls out of the bone, the preparation becomes unstable, and unfortunately the consequence of that is you damage the site. So this is hardly doable. With a rotating drill, it's hardly doable because the drill jumps around inside these compartments. So the question then is, how do we do this? And the protocol that we've developed is to use the tooth as a drill guide. So that for some people is a little bit of an unusual and strange concept, but what it has done for us is to make molar tooth replacement entirely predictable. And for that reason, it's become the standard of what we do. Even in case 1 scenarios, which I've just showed you, where there's plenty of bone, where you think you can just purely do a drill preparation, we don't do that. We keep the tooth in, and we do the same protocol as for the case 2 that I'm now showing you. So if you can visualize that in your mind, the case 1s and the case 2s, we're essentially dealing with in the same way, and that is to use the tooth in the site as a drill guide. In other words, you don't get into the situation that you see here, where you're faced with empty compartments and spindly bone septums that you know will be destroyed by your drilling protocol. We don't go there. We leave the tooth. And we use the tooth as a drill guide. So the protocol here is that we cut the tooth off, we cut the crown off horizontally at gingival level, more or less, make it nice and flat so that you can see and you can reference it for your measurements of your drills. And what we then do is we prepare with a high-speed handpiece a starting point into the dentine under control conditions. You can visualize it, you can see it, you can stop and look at it, there's no bleeding. If you don't like it, you can adjust it. You can move it around in the dentine until you're entirely happy. And the criteria to be happy with the drill position here is to be slightly mesial of the midpoint and slightly palatal of the midpoint. So I come back to that reference in our protocol. You want to be mesial and you want to be palatal. We're talking about upper jaw here. Once you're happy with that position in the dentine, you can plunge your drill through the dentine until you fall out the other side into the bone, which is in the trifurcation of the tooth. This obviously works for any form of divergence of roots. If you've got a completely tapered tooth where the roots are fused together and it's conical, you don't really gain anything by drilling through the tooth unless there's bone apical to the conical root, in which case it does help you to drill through the conical root, the fused roots, into the bone beyond the tooth. So just visualize that. But typically the first molar would have some divergence of root. In other words, there's some bony volume between the roots. You'll be drilling through and up into this area. Right, so that's our start. We then, having established a pilot hole, mesial and palatal of the midpoint, we use tapered implant drills to drill through the dentine and the tooth to depth. The depth that we're looking at in the maxilla would typically be at the point of the sinus floor. Not always, but typically. So in some cases where you've got plenty of vertical height of bone beyond the apices of the root, there would obviously not be an indication to go to the sinus. But where the roots are shorter and sinus approximating like this, it's inevitable that we go to look for the floor of the sinus to engage that to be part of the osteotomy to stabilize this implant. So when you're drilling through the tooth like this, you'll find that you're using a rather long implant drill because you're referencing to the dentine coronally. And the ultimate implant will not be at this level. Ultimately, the implant will be down here where the buccal crest of bone is and 2 millimeters below. So the ultimate implant will be much shorter. But the pilot drilling through the tooth, you're going to be using long drills. The other thing we do with this is not to use your brand new pristine set of lovely implant drills, but to keep a second set of implant drills for the purpose of cutting through the tooth, because obviously the dentine will degrade these drills quite quickly. So keep a separate set to do the dentine cutting with. They do cut the dentine quite efficiently, but the great thing about this technique is the smoothness and the predictability with which you can cut through the tooth. You can control the osteotomy that's being prepared below completely. You can control the direction and the placement completely. At the point that we drill to 6 millimeter taper drill, we then take the tooth out. So we always go 3, 4, 5, 6 millimeter taper drill, then section the tooth into its 3 compartments and take out the tooth. The ease of that extraction is another benefit of this technique, is that you've already created a void in the middle. You can easily elevate the roots into the center and they come out very easily. The next thing to do is to check the compartments for any residue of tooth fragments or pathologies or foreign materials that may be in those compartments. And the best way to do that is obviously with magnification and light. So this is typically what we see when we've taken the tooth out. We've had a 6 millimeter drill go down through here. And the bone that you're looking at here, although it looks quite coronal in the socket, it's not. The perception is lost on the photograph, but that bone and that preparation lies way down here in the socket. It's fairly apical. But what you've got now is a very predictable positioning of your implant, and you've already generated the correct depth for the implant. That's key. You want to be able to verify the depth of preparation at this point already. So having drilled to 6, take the tooth out. The next thing you do is the tap. And the tap, you'll choose a 7 millimeter diameter tap would be the first port of call. But the length you now have to determine based on the buccal crest of bone and the position of the sinus. So one can use an extended length periodontal probe to make a measurement of that, and then take the tap to site, and at the point at which you're happy with it, take a radiograph, because this is the first opportunity you've got to measure the depth of the device that you're going to use because it's the first time that the tooth is out of your way. Again, the criteria here is that we're looking to engage just the tip of this implant or the tap into the floor of the sinus to gain primary stability in that area. We're not looking to extend it further than we need to. And in this coronal aspect, we're looking to be 2 millimeters below the buccal crest of bone. So they're distinct criteria with which to determine. If you're not happy with the tap at this point, you can obviously default, as I said, in two respects. You can either change the length of the tap at this point or the diameter of the tap. If you need to make such an adjustment, go back with the second increment of tap that you've decided upon and place it to the depth and take another radiograph. If you've satisfied the criteria with that tap, then you're ready to place the implant in a very predictable way. And you can see that the implant is placed here. There's plenty of space between the implant and the buccal. There's probably 2.5, 3 millimeters of space to the buccal. There's a greater space to the palatal, but mesiodistally, there's reasonable approximation. And you can see that implant in sight now is exactly as the tap was in sight. So there's the predictability of using the tap. We've got the nose of the implant just into sinus floor with good depth below the buccal crest. And now we can choose the temporary healing abutment of adequate dimension. In this case, the green part indicates that it's a 6 millimeter restorative interface and it's a 2-part temporary healing abutment. Some approximation of soft tissue is done. And again, I say you've got the option of customizing this temporary abutment because it's a 2-part. You can do customization of it, adding resin or composite to it. You've also got the option of placing materials to close the spaces. And what we're doing with this, and have been doing for a couple of years now, is just to use a collagen sponge, a resorbable, obviously collagen sponge, bovine-derived material, just to tuck into the soft tissue areas here to obturate the space so that you're protecting the blood clot from being washed out. We place that collagen sponge just coronally in the soft tissue. We don't push it down into the socket, into the bony areas at all. The intention is just to create a lid over the sockets where blood can fill and where the patient can't wash it out or food debris can't go in. And in that way, we have very predictable healing. Obviously, individual operators may choose to put grafting material into there. Any kind of grafting material that you can come up with can probably go down there. But the question is to whether you need it and what the risks of that are long term. There are also cost implications with doing that. It seems to be coming out in the literature now that one of the long-term consequences of putting biomaterials, especially non-resorbable materials, into these voids is that long-term they can predispose to late infections and implant losses by peri-implantitis, sometimes years later. So we have to take a view on that. Our view has been, in recent times, in the last number of years, not to put any materials into the socket, resorbable or non-resorbable, other than the collagen sponge, and allow the body to fill with bone. And we've had good predictability that way. So if you look at this, the voids, the approximation of the soft tissue around the temporary abutment, the healing, this is suture removal at 9 days. It's practically closed. 1 month later and 4 months later. You'll notice if you look critically at this buccal plate, that already at 4 months there's a flattening of the buccal plate, whereas here it was quite convex. And it's for this reason that we always strive to keep the implants of the smallest size that we need. We're not trying to fill the socket. We want to stay out of this resorption zone with the implant device. And secondly, by positioning the osteotomy accurately by drilling through the tooth, we want to create physical space between the implant and the buccal, because this is, after all, a resorption zone. We also want to take into account the biotype of the patient and the amount of keratinized tissue. That gives us some hint as to the nature of the resorption pattern in any individual patient to some extent. So you see typically mesiobuccal root pathologies. Chronic pathologies like this, we're happy to extract the tooth, debride the pathology and place the implant. And these areas you can see very often, because it's mesiobuccal roots that are involved in pathologies, they do not form part of the implant site at all. And that's a fortunate attribute of tapering away as well, is that you stay away from these mesiobuccal pathologies. So even if this buccal area is somewhat deficient, we can still place the implant. Obviously, if you've got an extensive buccal deficiency, it calls for a completely different protocol, and most of the time we wouldn't place that implant. Notice the bone height maintenance, initially the remodeling, but the bone height maintenance is very good over, 6 years. Again, a zirconia monolithic, milled to the titanium passive abutment. We've got a little bit of buccal veneering on this one. And you can see here again a slight deficiency that develops in the mesiobuccal. But overall, we can maintain these areas extremely well with this protocol, immediate placement into extraction sockets. 6 years later, it's interesting to see, this is initial, this is 6 years later. You can see the natural premolar and the canine have undergone some recession. And so too, the implant restoration is showing some loss of soft tissue height. So we have to accept that there's no such thing as a stable mouth, in the sense that the gingival margins regress, whether it's an implant or a natural tooth, the buccal plates, the buccal volumes regress over time. And with our older implant cases that are 20 and 30 years old, sometimes these are very marked. And so in choosing devices and positioning them and choosing the depth that we place them at, we must think long-term about these buccal volume changes. And it's for that reason that we encourage you to stay away from the buccal, place the implants plenty deep enough so that you stay out of those resorption zones. This is just another example of a lone standing molar drilled through, implant placed. This happened to be used as an abutment for an overdenture with a ball abutment on it. You can see it punches into the sinus. There's a degree of bone that fills over the top of it over time. That's fairly typical. Right, so that's case 2. Case 2 is very important to understand. We're going to do that in the demonstration. You'll have the opportunity to do one of those yourselves on a model, to cut through the tooth, cut the top of the tooth off, drill through the tooth, collapse the tooth inwards, go in with a 7mm tap and place an implant. So that is by and large the bread and butter way of placing a max implant. And it's a very predictable way of doing it. Case 3 is where we've got no bone in a socket, and that's extremely difficult to deal with. Initially, when the device was configured, we thought that these were the prime sockets for max implants, but completely the opposite is the case. These are probably the poorest choices of sites for max implant and the most difficult to deal with. We've got, within case 3, we've probably got 2 subsets. The one is this in front of you, which is where you've got a single compartment and the sinus membrane is looking at you. The difficulty with this is that you can't drill apical to the site to gain a purchase point because there's sinus there. There's nothing there. And so what you're obligated to is to maintain an implant in the depth of the original socket, but try to position it palatally, and that's what's almost impossible to do. The only way in which you can achieve that is to drill against the palatal wall of the socket incrementally with ever increasing dimensions of drills. So you might even in this case start with a 6mm taper drill, and then you would use a max drill at a 7mm diameter and an 8mm diameter to try and gain an increase in diameter here in such a way that there's lipping. If you can get lipping generated at this point here, then you've got a feature which will resist the buccal displacement of the implant when you put it in, and you may stand a chance of achieving correct positioning. So we would get the lipping going and then put a tap in to verify that primary stability can be achieved. What you find in a site like this is because it's wider here against the buccal than it is palatally, the implant or the tap continuously displaces itself to buccal. So it may be tight, and as you rotate it, it'll fall to buccal, and then it'll lose all of its stability. And so these are very challenging. The second subset of case 3 is where you've got bone apical to the very tapered socket, and those are much easier to deal with because you can drill beyond the depth of the socket, gain a point of purchase, and increase the osteotomy in exactly the same way then with a sequence of taper drills, ultimately a tap, and then an implant. But the number of cases you'll find like that are extremely few. In other words, where you've got an empty socket and still space to the sinus. They seem to be mutually exclusive, those features, anatomical features. So you see in this case where we were able to place an implant, there's not a lot of bone visible around the implant in this two-dimensional view. But over time, what one anticipates is that there's buccal fill and palatal fill. And in fact, this implant was immediately loaded. You see here temporary cylinders attached to the implant. It was loaded by virtue of the fact that it's connected to adjacent implants. We don't ever load, or certainly my philosophy is not to ever load single max implants, but if they can be connected to other implants in an arch, we would certainly consider that. And at 6 years, you can see there's definitely an increment of bone around this implant, even over the apex of this implant. And what we see is increasing density of that bone over time and reorientation of the trabeculae, indicating the lines of force dissipation from the interface. So despite the apparent appearance of very little bone, it's a very stable implant. Let's say a few words about maxillary second molar sites. These are very difficult sites, and so I say treat them with caution. The reason being they're high resorption zones. In any biotype, they're high resorption zones, but in a thin biotype, probably a zone that you don't want to treat with a max implant, or maybe not any implant. The anatomy in this area is very difficult, and you definitely need to take into account the biotype to consider the resorption pattern. In this case, we have a patient with a buccal swelling. There's a root fracture down the palatal root. Curiously so, because it's a pretty much unrestored tooth. The patient presents with that swelling. We put the patient on oral antibiotics for 5 days, and on the 5th day, the swelling is no longer fluctuant. There's no pus drainage. We take the tooth out, and we do a preparation. Now, this preparation is very difficult. You'll see that in order to gain depth below the crest of bone buccally, and also to engage the implant below bone on the distal aspect, we have to go very far down, very deep, relative to the mesial interproximal height of bone. And that's a problem, because all of this bone here that we've passed by would have been probably the best quality of bone in this entire compartment. But we can't utilize it. We have to move past it for the sake of the most apically positioned bone, which is here and on the buccal. And in so doing, this device exposes itself more and more to the sinus with almost no bone engagement to be had. So in many cases, this would prevent you placing this implant at all. By using the tap and defining the amount of stability that we've got and the insertion torque that we've got, we were able to place this implant. And you see that the implant's in sight there. Notice the depth from the interproximal height of bone to the restorative interface. It's an exceptional depth. It's probably 7 or 8 millimeters to the crest of the soft tissue here. So an unusual scenario. What seems to be the case is that this apparent distal height of bone, which doesn't look as severe as it does step down here, that interproximal peak of bone seems to be associated with the distal furcation of that tooth. And when you've extracted the tooth, you pretty much lose that tiny point of bone, and the real platform of bone is some way down here, and that's why you get this big step back between the mesial and the distal. So this is very difficult anatomy to deal with, and may preclude you placing these implants some of the time. This is a 9 millimeter diameter implant. It's probably a 9 by 9, could be a 9 by 7. I think it's 9 by 9. And on that 9 millimeter diameter implant, we can use a 7 millimeter restorative interface, which is a lovely interface to use for a molar because it's pretty much the mesiodistal dimension of an upper molar. But obviously, it's a minority of cases where we can use a 9 millimeter diameter implant. We most typically in the maxilla, probably the most used implant in the maxilla would be an 8 millimeter diameter implant. Right, we see it at 20 months and at 4 years. The implant still is doing very well clinically. The odd shape to the top of this implant on the radiographs is due to the bending of the radiograph in the palate. But you can see markedly the reorientation of the bony trabeculae as the site matures and the bone reorientates itself to the ankylosed interface. So again, there's a lot of talk made of whether pocket depths, if you consider that a pocket at all, can be sustained. 7 millimeter, 8 millimeter pocket depths can be sustained in health around an implant. And my answer to that is definitely it can. It's not equivalent to a periodontal pocket. Here we see another second molar site. There's an apical pathology here on an endodontically treated tooth. It's a chronic pathology. We can place an implant in the site. It's a more favorable site than the previous one that I've shown you. But again, look the step change between the mesial and the distal here. Quite significant yet again. More so than you would have anticipated looking at the pre-op. So we have to go deep enough to accommodate the implant below bone on the distal. It nudges into the sinus. We've got good primary stability. We can verify that with a tap again. The tap in sight with a connector to the wrench. And over time you can see the reorientation of trabeculae. So that would have been a check at 3 months, and then we've restored the case from placement 5 months and 4 years. Notice the change in the trabecular pattern here. And at 6 years, it's still doing well. Adjacent max implants, this question always comes up, so we've got a couple of cases to show. It's a very risky thing to do, to place 2 max implants adjacent to each other in one procedure. And the reason for that is simply the risk of loss of control of positioning and the risk of approximating these 2 implants. In this instance here, we had an integrated max in sight when we lost the second tooth 8 months after. You can see this was 8 months existing when this tooth went. So this is a safer scenario where you do 2 implants adjacent but not simultaneously. So just bear in mind the risks of doing them simultaneously. One of the difficulties that you'd immediately recognize here from any of your other implant work is that this interproximal height of bone between 2 implants you'd expect to lose almost immediately. So let's see what happens to that. The same criteria applies. We use the max tap in every case, taking it to depth in the pilot preparation that we've done, verifying depth of placement, position to the sinus, insertion torque and primary stability. Again, if the tap isn't working here, we can change length and diameter until we've got what we need and then choose the appropriate implant accordingly. So here we see 6 months later, this is 6 months post-placement when the implants are both in sight, mature, integrated and doing well. Notice the lipping of the bone around the top of this implant. There's sinus membrane and there's bone incrementing up the side of the implant. And at 16 months, you can see much more of that. So that's a very satisfying picture to see because we know that the force generations there are completely within the range of stimulating bone response. Both of these again are restored on passive abutment. Notice the interproximal height of bone that's sustained. It's probably better than we hoped for, and the reason that we can allude to for it being so is that we've got good fit with passive abutment, maintaining stability of the joints with gold screws. We've got platform switching, etc. Obviously, if the 2 sockets are really tight together, you could take some freedom to move distally because you don't have a distal tooth here. So in this case, there's probably reasonable dimension between the 2. And so you don't have to work too hard at it, but obviously more separation is better. You don't have to fight it mesially to the same extent. The risk is this implant going distally. But if it's a second implant, there's not going to be an impact of that. You'd rather choose more space between the 2. So there again, sometime later, look at the increasing density of bone here. Good to see. Interproximal bone still there, 32 months and 40 months. By the way, this void that you see, this apparent void under the passive abutment, is just that. It's a void. And it's created in the design of this part. The passive abutment part here is designed to have an edge fit. You know, if you look at it end on around the perimeter, there's a rim that fits to the interface of the implant, and inside of that rim there's a machined recess. And on radiograph, if you get it perfectly perpendicular to the long axis, you'll see that void. And that's all good and it's all in order. People get scared when they see that. But the intention here is that the fit is on the edge, on that perimeter lip that's machined there, and in that way we get the maximum clamping force at the outer ends of the platform. If you don't have a recess within, you have a large surface contact area, And the problem with that is that you have micro interferences across that platform and you don't have as much clamping force on the edges. So it's far more beneficial to have the machined recess and the clamping force on the perimeter. Sometimes on panoramic radiograph, this passive abutment, because it's so thin, and also it's got a recess within to accommodate the external hex, on a panoramic radiograph it can look absent. And people get frightened at that because it looks as though you've got a great big vertical misfit between your restoration and the implant. But it's simply an artifact of the radiolucency of that thin part. So just bear that in mind. Right, immediate loading of maxes. I've said that in my philosophy of work, my practice, I don't load single maxes. There are some people that do that. I don't agree that they should be doing that. But if we have multiple implants, we definitely load the maxes. That was the primary intention, is to treat full arch cases immediately with site-specific implants throughout. So we definitely load those maxes. And you can see here's a standard abutment. Again, it's got edge fit. This is a pre-machined standard abutment, old style, with a temporary metal cylinder on the standard abutment with a bar connecting. These are pre-manufactured bars that are available that we incorporate into the acrylic work for speed to manufacture a bar from pre-made parts. And then sometime later we do definitive ceramo metal in this case on passive abutments on each case. Just the point about loading single maxes is that people say, but if you've got so much insertion torque, why don't you load them? Well, you might have 100, 120, 140 Newton centimeters of insertion torque. The problem with that is it doesn't mean that there's primary stability. The two things are different. Authors and speakers continually equate insertion torque and primary stability, and it's nonsense. Insertion torque is a representation of the amount of interfacial friction between the device and bone. It doesn't give you any idea about three-dimensional stability. And it's very prominently illustrated by max cases. For example, in the maxilla, where the site can be narrow from mesial to distal, you might have very high insertion torque, but there's no bone, buccal, and palatal. And you can, despite the insertion torque, you can tip the implant. And it's for that reason that I say you cannot equate primary stability and insertion torque. There's not a linear relationship between the two. So don't be fooled into thinking because you've got 100 Newton centimeters of insertion torque that you've got enough primary stability to load a single max. On the contrary. Here we've got an example of a unilateral case. This wasn't a full arch. It was 3 implants together where we've immediately loaded, because you've got 3 implants together, you've got enough mutual protection to immediately load. And this resin here, this composite, is an illustration of where the occlusal plane lies on the immediate restoration. Sometime later we've got the definitive. Right, max in minimal bone. We've seen a number of these cases already. It appears to have no bone, but there's obviously buccal and palatal infill to contribute to that three-dimensionally. In some cases like this, this was an overdenture case that had a retained distal abutment. In the front we had implants. The patient wouldn't have a bone graft, so she hung on to a partial overdenture. Eventually, when the max came along, we could treat these sites with no bone graft and convert to a full fixed restoration. So I mean, imagine the difference in morbidity, cost, time, etc. between grafting this maxilla, probably from iliac crest, versus just extracting the tooth and putting in a wide-body tapered implant. So we've got a real solution, minimally invasive and saving cost and procedures and morbidity for our patients. Special considerations, we've looked at most of these already. Sinus communications. People obviously concerned when they start to do max implants that they might prepare into the sinus, and we do that a lot of the time intentionally to prepare into the sinus floor. But also simply by extracting teeth very often we create sinus communications, perhaps more than we even know in the past that we did or were doing. So we have to get used to that idea that sinus communications can exist, can even be created in the process of doing a max implant, and that we become comfortable with that and how to deal with it. By and large, the only way we deal with it is to put an implant in the space. That's all we do. No other elaborate procedures are necessary, even to repair membranes. Very often, if we've cut into the sinus floor, we've damaged the membrane, we simply place the implant into site and it heals over it. What we try not to do is to extend far into the sinus. The buccal plate is pretty much an absolute requirement, is that it should be intact. The socket voids I've spoken about, you have individual preference of grafting or not grafting. We've tried various approaches over the years, but I think the simplest is the best approach, and that's what we've done consistently for the last number of years, is to leave it to the blood clot. The blood clot will take care of it, as it always has. But we assist this by putting a collagen sponge in the soft tissue aperture to protect that space. If we don't do that, what we've seen happen is that especially diligent patients go home and rinse and rinse and rinse, and when you see them a week later, there's a completely empty space, and you can see all the threads of the implant running down in the empty spaces. So to prevent that, we're doing a couple of things. We're putting in the collagen sponge, lightly adapting the tissue. We're trying to use an abutment to fill as much of it as possible. And then furthermore, we're instructing the patients not to rinse for a week, to leave it alone. Let the blood clot mature and take its course with vascularization and ultimately bone fill. The depth of placement is really important. I see far too many max cases that are placed way too shallow, and that's a recipe for problems later and long-term morbidity, because the threads will become exposed coronally, and there's really no simple way of dealing with it other than ultimately removing the implant and starting again. And immediate loading we've just discussed. This is the product that I like to use. It's a Septidont product, hemacollagen. There are a couple of benefits to this. One foremost is that it's extremely inexpensive. It's a very cheap material. It's hardly even a cost. It's much cheaper than the collar plug products, for example. It's a fraction of that cost. The other feature of it is that it's a very low density collagen. A collar plug is a very dense material, and we've tried that in these voids, but because it's so hard and dense, it's difficult to work with. You have to cut it to shape to fit it in. Whereas because this is very spongy and very low density, you don't have to cut it into a specific shape. You just cut off a piece from the block that you think you need, but it should be 2 to 3 times bigger than the space that you're going to fill, because it's that collapsible. You take it to the site, and because it's so low in density, it immediately wicks blood into it. So it goes red immediately, and that's great. You want it to wick blood to become part of the hematoma, and then you simply just lightly adapt it and you're done. So we really like this material. We've had very good healing with it and no morbidity with it. The complications of MAX are technique related. They mostly relate to exposed threads, and these are because of inadequate depth of placement, that the buccal plate was not intact, and that you haven't stayed away from the buccal plate. So the technique must be respected. Infection can occur around these implants. One of the risks is the empty socket voids. There are always empty voids around these implants. And if you allow debris to get in there, pips and crumbs, that can predispose to infection. And that's why we like the protocol of putting the collagen sponge in, letting the blood fill, and not washing the blood out. But existing pathologies can also be left behind. Obviously, these roots are being removed for a reason, and that's because they've got pathologies, and we need to look to cleaning up those pathologies. And obviously, that's a very personalized thing. Each surgeon has their own approach to that, and there's a lot of surgeons nowadays that are doing rinsing protocols with different materials. Some are using iodine, some are using chlorhexidine, some are using hydrogen peroxides, or perhaps even a combination of them. So you have your preferences. And how we deal with the socket voids, I've discussed that. Oral antral communications can be a complication of MAX implants, either by the act of extraction of tooth or the act of preparing the site. But both of those are completely non-issues if we place the implant, because they're dealt with by the implant. The real bugbear of oral antral communications would be if you lose the implant in the early stages. If you lose it after a week or 2 weeks or 3 weeks, you may end, having removed the failed implant, you may end up with an oral antral communication that you need to deal with. So you need to have skills in this area, or know what you'll do if that happens, if you're confronted with that, or have someone that you can refer to who will understand the situation for you. Obviously, the risk of communication is in the shallow sockets. If it's a very deep socket, even with the communication, they'll normally heal uneventfully. But the very shallow ones, where you may have had a 7 millimeter long implant and you lose it in a week, you're going to have a communication. Because it's short, you would have gone into the sinus, and it probably wouldn't have had time to heal. So you need to have the skills on board to deal with that in the event that it should happen.